This lecture is the drugs affecting the lower respiratory system. I'm just going to start it over just for the sake of those few who had to leave, as well as just so I'll have it in its entirety for other semesters. This is the concept map for the lower respiratory system drugs and is the information that about each one of those classes for the lower respiratory system. All right. This is just going over the physiology of the lower respiratory tract. It is virtually sterile because of the various defense mechanisms in the upper respiratory system. It does have protective mechanisms. All the tubes in the lower airway do have goblet cells, which do secrete the mucus and entrap any particles. And microorganisms are then removed, of course, by those cilia that are lining the lower respiratory tract. You do have gas exchange, perfusion, and respiration that occurs in the lower respiratory tract. The lung tissue does receive its blood supply from the bronchial artery that does directly branch off from the thoracic aorta. And we do get our ventilation via the lower respiratory tract, whereas the active breathing is controlled by the central nervous system. There's just a picture of the lower respiratory tract and what we're talking about. In talking about the pathophysiology of the different disease processes of the lower respiratory tract, there's acute bronchitis that is caused most frequently by viruses of specifics being cold, influenza, whooping cough or pertussis, and measles being what most often causes that acute bronchitis. Then there's also asthma, which is characterized by recurrent episodes of bronchospasm, and then that bronchial muscle spasm that leads to a narrowed or obstructed airway. When that becomes an emergent situation, it does turn into what we term status asthmaticus, which is an emergent situation where we're needing to put in an airway for that patient because the asthma has progressed to such a degree. Chronic airway limitation, or CAL, is just the umbrella term that describes that gradually progressive degenerative disease such as chronic bronchitis, emphysema, or repeated severe asthma attacks. We also term that as COPD, which is chronic obstructive pulmonary disease. There's also CORD, which is chronic obstructive respiratory disease. And then COAD, which is chronic obstructive airway disease, or COLD, which is chronic obstructive lung disease. All that could be termed under chronic airway limitation. It's just a matter of wording and what you want to call it. For the purposes, mostly for this class, I'll refer to it either as CAL or COPD. But specifically in CAL, that's where we have gas exchange being lost and we have an increased energy to breathe. Chronic bronchitis is long-standing, largely irreversible inflammation of the bronchial tree, and it also can be caused by chronic sinusitis too. And then this is just showing you a picture of what asthma looks like from a standpoint in the lungs, here being your normal airway. Then you've got your asthmatic airway, where the smooth muscle there gets tightened and constricts that blood flow or that airflow. You have that inflammation that occurs there in that airway that causes some of the constriction there that asthmatics complain of. Then this is showing you what bronchitis looks like. You've got your normal bronchi, and then this is a bronchi with bronchitis. You can see that irritation and that inflammation down into the bronchi, as well as that excess mucus production. This is COPD Cosby, as a couple of students from a few semesters ago named him. He is, this is just giving you a visual picture basically of what COPD looks like, just kind of a visual reminder of what it looks like. And with that, it just is just one of those things to help you whenever it's test taking time to remember what goes on in that, in that disease process. This is showing you a picture of COPD. This is that normal airway, and this is the airway with the obstructive chronic bronchitis. You can see that thick, sticky mucus that happens here that blocks the airways instead of clearing them, as well as that inflammation and swelling that happens. Over here you've got emphysema, which is where you've got, this is the normal alveoli where that air exchange occurs. Then over here you've got the damaged alveoli and where the air becomes trapped, making it difficult for the patient to breathe. And then down here you've got a picture of the healthy air sacs, whereas over on this side you've got the collapsed and weakened air sacs that have the excess mucus, showing you what occurs during COPD. This is cystic fibrosis Cindy, and giving you a picture of what cystic fibrosis looks like. Again, in cystic fibrosis, it is a genetic condition. You can have people who are just simply carriers for the disease, as well as people who are dominant and actually are heterozygous and actually have the disease. And with that, it just causes that additional thick mucus production. Also, causes a problem with their absorption from the standpoint of vitamins and enzymes in the digestive tract. They can get those fatty, stinky stools, that's steatorrhea. A lot of times parents will bring their kids in saying that they were kissing on them and that they tasted salty whenever they kissed them, and that's one of the kind of the hallmarks of that salty taste on their skin. The biggest thing is that it causes a lot of respiratory problems. Previously, in years past, the life expectancy of a cystic fibrosis patient, they would be doing good if they lived into their 20s, but with medications and medical advancements, actually has progressed until that they're actually living much longer, more productive lives now than what they used to. But the big hallmark of them is having to do a whole lot of chest physiotherapy and doing a lot of breathing exercises and breathing treatments and things. This is just showing you a picture of that healthy lung and bronchiole versus one with cystic fibrosis, where you can see all of that inflammation as well as that increased mucus secretion. This is giving you a picture just simply of a normal chest x-ray, kind of showing you what the normal chest x-ray looks like. The big thing about the chest x-ray here is, in showing you a normal one, I just want you to make sure that you notice the different landmarks and things. Noticing that you can see on chest x-ray bones, more dense, material is going to show up lighter, whiter looking. You can see, the clavicles here. You can see the vertebrae. You can see the different ribs. The big thing, now this of course has been drawn on so that you can actually see the structures and place some landmark to things. But here you see this nice pretty arch on the lungs, showing the base of the lungs. That's showing you good airflow, good air movement. You can see where the heart sits there into the chest cavity. You also can see down here into the upper part of the abdominal cavity. Often whenever patients are, constipated and have a lot of stool in their bowel, you will actually see kind of like a dark grayish, look here that will actually show you the ascending colon, the transverse, and coming down into the descending colon. You can see that they're full of poop on x-rays a lot of times. The big thing about chest x-rays is making sure to acclimate yourself over the fact that you have a, that your right side is the patient's left side and vice versa, and making sure that you take a good look at like finding your normal landmarks so that you can identify the abnormal. and making sure that you understand how the chest x-ray was taken. A PA and lateral chest x-ray means a posterior anterior approach, as well as a lateral view. Those patients are taken down to the x-ray department where they actually stand up in front of the x-ray film or the x-ray box to give them a good picture of the lungs. If a portable x-ray is done at the bedside, you have to keep in mind they're laying down, so all of their anatomy is going to kind of by gravity fall back. So it's going to actually make that heart look enlarged, which the radiologist will report as cardiomegaly, which is not incorrect. He has to report what he sees, but you have to understand to interpret that with caution and to report that to the physician with caution. This is showing you a picture of an asthmatic patient chest x-ray. The biggest thing that I want you to understand here is the fact of where you lose that nice pretty arch in the base of the lungs there. A lot of times asthmatic patients, the base of their lung fields on x-ray are going to show up more flat, which is what you see here. Otherwise, the chest x-ray doesn't really change that much, but you do see just more of a flattened approach to the base of the lungs. This is giving you a picture of the chest x-rays in a COPD patient. This one being normal, which is not great quality, but I have shown you a normal one anyway. Then this is the chest x-ray from the PA approach, and then this is from the lateral approach, and mainly just a lot of this clouding, this hazy kind of look down here in the lower parts of the lungs. That's that COPD approach that you see happening there. This is giving you a picture of what the chest x-rays would look like in patients with pneumonias. This being a right upper lobe pneumonia. Here you can see this is a nice pretty picture of a middle lobe pneumonia. And also keep in mind from an anatomy perspective, you have 3 lobes on the right side and only 2 on the left. Only 2 on the left because of the heart. So just from an anatomy perspective, keep that in mind. But you can see this this big pneumonia sitting here in this right middle lobe. Over here, this is a right upper lobe pneumonia as well. And then here is a left lower lobe. You can see how that whole left lower lobe is almost completely covered, just to give you a picture of what pneumonia looks like. Also, in talking about the pathophysiology from a standpoint of emphysema, it is an abnormal distension of the lungs with air, characterized by a loss or degeneration of the elastic tissue, disappearing capillary walls, and a breakdown of the alveolar walls. Basically, where you've just those air sacs have just become so diseased over time and so enlarged over time that they just no longer provide for that air exchange to happen, that gas exchange to happen. Pneumonia is an inflammation of the lungs. It can be caused by bacterial or viral invasion of the tissue. Or you could have an aspiration pneumonia where you aspirate foreign substances into the lower respiratory tract, specifically, in like those tube feeding patients and in stroke patients who, can't swallow appropriately. And then, of course, cystic fibrosis, like we talked about, is a hereditary disease that affects the functioning of the body's exocrine glands, which would be specifically those mucus-secreting and sweat glands. All right, moving into the different drugs, we've got our mucolytic drugs. Those drugs break down mucus. They can be administered by nebulizer or by direct instillation into the trachea. Now, obviously, we are not going to be the ones to directly instill it into the trachea. That's going to fall into other more capable and trained hands than us, but we could potentially administer it by nebulizer, but a lot of times that's going to be the respiratory therapist that's going to do that as well. Mucolytics are usually reserved for patients who have a major difficulty mobilizing and coughing up secretions, specifically in the cases that we have talked about, specifically in cystic fibrosis patients. And our prototype drug here is acetylcysteine, or by brand name is Mucomyst. All right, so in the pharmacotherapeutics, for Mucomyst or acetylcysteine, it is used to liquefy thick, tenacious secretions. It is administered by inhalation Its onset is in 1 minute. It is metabolized in the liver, and it is excreted somewhat in the urine. The pharmacodynamics, it does split the disulfide bonds that are responsible for holding the mucous material together. That disulfide bond is part of the reason why it is a very distinct smelling nebulizer treatment, because it smells like rotten eggs. And I promise you, once you have ever smelled it, you will never forget it, and you can easily pick it out from anything else that's administered by nebulizer. And it definitely has a very sulfur-based rotten egg type smell to it. When it splits those disulfide bonds and that keep that mucus material together, that in turn decreases the tenacity and the viscosity of those respiratory secretions, which is what the goal is to liquefy, those secretions. So that's where it's working in the body and what it's doing, in a supervised environment. In talking about maximizing therapeutic effects, we do want to make sure to administer an inhaled beta agonist before administering acetylcysteine. Now, we're going to talk about beta agonist in just a few minutes, but what you need to remember there is when we say beta agonist, that's a stimulation of those beta cells. And with that, the reason we do that is so that we can open up the airway, so that the acetylcysteine can actually get down into the airways and get to the mucus. Because our goal with the acetylcysteine is to thin and liquefy that mucus. But if the airways are so constricted that we can't get the acetylcysteine down there, it's not going to be able to do its job. So we want to make sure to give an inhaled beta agonist before the acetylcysteine. An example of an inhaled beta agonist would be such as albuterol. In order to minimize the adverse effects, we do want to inform the patient that nebulization may produce that disagreeable odor, that sulfur smell, that rotten egg smell, but that odor is transient according to textbook terms. However, according to Ms. Kilcreast's terms, in the hospital setting, from what I have learned, it's not too transient. It usually kind of sticks around, in my opinion. All right, so for patient and family education, we do want to make sure to explain the rationale to the patient and family for why they're receiving the acetylcysteine. We do want to inform patients that they must not take the drug without the assistance of a respiratory therapist. Again, like I said, occasionally I have seen it used in a home setting, but that's usually under certain guided, type conditions. We do want to teach patients and their family members all aspects of good pulmonary hygiene. Also, other nursing implications for us. The solution, because it's usually going to come in a glass vial, it must be refrigerated and used within 96 hours of, whenever it's opened. And because of the fact that we're loosening those and liquefying those thick, respiratory secretions, we want to make sure that we've got suction equipment nearby. At the bedside, so that we can easily use that if they start coughing and almost choking, so to speak, because of all of the mucus. For ongoing assessment evaluation for the patient that receives acetylcysteine for its mucolytic effects, we want to assess them for proper techniques of pulmonary hygiene and assess their respiratory status post-treatment as well. Acetylcysteine is administered for the purpose of mucolysis by inhalation or direct instillation, like we talked about, into the trachea. However, we do give acetylcysteine in the PO form. We can do it, can give it in the PO form when a patient has had an acetaminophen overdose, or acetaminophen, also commonly known as Tylenol. If they have had an acetaminophen overdose, we can administer acetylcysteine for that, and it will help to decrease the effects of the acetylcysteine. It is also used for contrast-induced nephropathy prophylaxis. So if we know we have a patient who has poor kidney function and they really need to have a CT or MRI with some contrast, and we're worried about those kidneys, we can give it to them for contrast prophylaxis, or the nephropathy prophylaxis for those patients. All right, when we're talking about bronchodilators, they are used to facilitate respiration by dilating the airways. They can be administered orally, parenterally, or by inhalation. Inhalation is the most frequent method that we use them, either in a metered dose inhaler or a dry powder inhaler. And these particular drugs are called beta agonists because they stimulate the beta receptors. Also sympathomimetic because they mimic the sympathetic nervous system. One of the actions of beta stimulation in the sympathetic nervous system is dilation of the bronchi and an increased rate and depth of respiration. And so at a therapeutic level, the beta agonist are specific to the beta receptors that are found in the bronchi. If they are given in higher doses, or they're not held to that therapeutic level, they're given a higher than normal amount of times or number of treatments or whatever, then you lose some of that ability and you actually will get some beta stimulation elsewhere. Now, in keeping that in mind, think about where your beta receptors are located. You've got beta 1 receptors that are located on the heart, and you've got beta 2 receptors that are located in the lungs. And so with that, remind yourself that you have one heart and 2 lungs, so that you remember the beta 1 and beta 2. And so that's what I mean by, if these drugs are kept at a therapeutic level, then they pretty much are specific to just the beta 2 receptors. But if you go much higher than the therapeutic levels, then you can get some stimulation of those beta 2 receptors, of the beta 1 receptors as well, like on the heart. Our prototype drug here is albuterol, or Proventil or Ventolin, if you've heard of that before. The way I like to describe this to patients as well as to students, this is your rescue inhaler. This is your 911 inhaler. Like if you're at the point where you can't breathe, you're coughing, you're having shortness of breath, you're wheezing, then this is your go-to inhaler for emergency purposes. So it's for rescue, or if it's before you call 911 kind of thing. It's not for maintenance, it's for rescue. All right, so our pharmacotherapeutics here, it is the bronchodilator that we use in managing chronic airway limitation and asthma. It is administered by inhalation, is excreted in the urine and feces. Its onset is pretty rapid at 5 to 15 minutes. Normally, once patients have had this medicine, it usually starts working pretty quickly. Hence the reason why it is a rescue or emergency medication. Pharmacodynamics, it selectively stimulates the receptors of the smooth muscle in the lungs, the uterus, and the vasculature that supplies the skeletal muscle. And so as a result of that, you get relaxation of that bronchial smooth muscle. Now keep in mind, when we were talking about the beta 2 receptors are located on the smooth muscle of the lungs, the uterus, and the vasculature. So because of that, that's where this is selectively stimulating, because it's a beta 2 agonist or a beta 2 stimulator. But you still can have some beta 1 stimulation, but for the most part, it is selective to that beta 2, as long as it's in a therapeutic level. All right, contraindications and precautions would be a hypersensitivity to the drug, adverse effects, tachycardia, palpitations, anxiety, tremors, headache, insomnia, muscle cramps, GI symptoms, The think about the systemic effects of a sympathomimetic type drug, where you would have an increase in the blood pressure, an increase in the heart rate. You would have vasoconstriction, a decreased renal blood flow, a decreased GI blood flow. So when you're thinking about that, that's the reason that you're going to see these particular adverse effects. So think about what that sympathetic nervous system does, so that whenever you're talking about a drug that's going to mimic that, you'll already kind of have an idea of what it's doing. Drug interactions, other sympathomimetic agents, beta-adrenergic blocking agents. That's when we talked about beta blockers. That's the beta-1 blockers. They end in that OLOL suffix. And the reason for that is because of again, that beta blockade that goes on there, that you can have some additional, if you don't have a very selective beta blocker, you could actually block some of the receptor sites for beta 2 receptors as well. Also, digoxin antidepressants and some potassium losing diuretics. Biggest thing that I care about there is that that it would be a potential interaction with beta blockers, and that dosing would have to be done accordingly. All right, so from a health status perspective, we do want to assess their medical condition and any contraindications to therapy, and making sure that we give that we understand the underlying disease process and what's going on, so that we can educate appropriately. It is a pregnancy category C drug, and the reason why for that is because if you think back to a couple of slides ago, when we talked about those beta 2 receptors being on the smooth muscle in the lungs, also the uterus and the vasculature, that's going to tell you why it's a pregnancy category C, because it could actually cause some uterine contraction to occur, and so that would of course not be good for that pregnant female. We do want to assess their caffeine intake. The reason for that being all those adverse effects as far as that tachycardia, those palpitations, the anxiety, the tremors, all of that being made worse or exacerbated with the caffeine, as well as taking these bronchodilators. They are frequently given at home. However, we use them in the hospital quite regularly, and also in emergency type situations. All right, and maximizing therapeutic effects. To obtain the correct dose of albuterol, you want to make sure to instruct them to prime the device. That means the first time that they're going to use it, you want to make sure to get them to, and this is talking about in the inhaler, in the inhaled form, you want to make sure that they prime the device, and they actually see like a little puff of smoke come out before they use it for the first time. Minimizing adverse effects. The patient should be encouraged to contact the healthcare provider to obtain other medications if their symptoms persist, rather than increase their frequency of albuterol use. If they're having a hard time breathing, if they're having coughing, if they're having wheezing, if they're having shortness of breath, we don't want them just to take more and more and more and more and more of their albuterol. We want them to let us know, so that we can turn around and get them maybe on a maintenance medication versus the rescue one. So they need to notify us if that's occurring. All right, in the patient and family education, we want to teach them that it is a rescue drug. We don't want them thinking that it's for maintenance. We need to teach them how to use the MDI and the way to appropriately use that. Now, y'all will learn that in your checkoffs for adult health clinic or lab. So make sure that you pay attention to that, but being able to explain it to a patient correctly. You also want to explain the importance of limiting caffeine intake, and the reason for that is to decrease the side effects that could come from the stimulation of those beta cells, specifically the beta 1 receptors at that point. Again, ongoing assessment evaluation, we want to evaluate for the symptoms of asthma and chronic airway limitation in patients that use albuterol, and make sure that it is getting better, and that it's not hanging around, that their symptoms are improving and not getting worse or or getting more frequent in nature. Albuterol is given for acute exacerbation of CAL or asthma. That is true. It is considered a rescue inhaler and is used for acute exacerbations of lung disease. And in talking about that, we have what we call short-acting beta-2 agonist, such as albuterol. And then there's also Zopanex as well as Max Air that fall into that category. Then we also have what are called long-acting beta-2 agonist, or LABA for short. We use those to help in some of those long-term patients who have some of that, chronic airway limitation. We'll use a long-acting beta agonist, and the reason for that is we'll use it in combination with a steroid a lot of times, a steroid inhaler, to be able to target those lung tissues better and to provide, more work or more relief long-term effect. But those are usually given in, and I say usually, a lot of times they're given in combination with an inhaled corticosteroid. Okay, and talking about respiratory anticholinergic agents. Inhaled anticholinergic drugs are considered first-line treatment for patients with CAL. Anticholinergic agents diminish the effect of acetylcholine, and they cause an effect, they have an effect on the vagus nerve. When you think about your cholinergic receptors, they will cause a constriction of lung tissue. So if we're given an anticholinergic, then that would equal out to being a relaxation of lung tissue. So that's where we're going to actually be working and improving things. In the respiratory system, the use of an inhaled anticholinergic drug stops that bronchoconstriction that occurs. And our prototype drug here is ipratropium bromide, or Atrovent. Pharmacotherapeutics is used for maintenance treatment of bronchospasm. It's not going to be one that typically we're given in an emergent type situation. It is administered by inhalation. Its onset is 15 to 30 minutes. Its pharmacodynamics, it antagonizes the action of acetylcholine by blocking the muscarinic cholinergic receptors. Muscarinic receptors being those that work on muscle. And so our goal with this drug is that we want the drug effects to be on the lung smooth muscle. So that's the reason why it works the way it does. All right. Contraindications and precautions. Anyone who has a sensitivity to ipratropium or to atropine. The reason for atropine being a contraindication, and if they have a hypersensitivity to that, is because of the anticholinergic effects of the drug, as well as atropine is an anticholinergic drug, so we would expect the same reaction to occur with ipratropium. So because of that, we want to make sure that we assess for if they have a hypersensitivity to either of those. All right. For adverse effects, a paradoxical acute bronchospasm, cough, hoarseness, throat irritation, and dysgeusia. Dysgeusia being a distortion of the sense of taste. When we talk about a paradoxic acute bronchospasm, where that occurs is when the patients don't prime that inhaler appropriately. They will have a acute bronchospasm to occur with that first dose, with the first inhalation of a newly opened inhaler. So that's why we always want them to prime that inhaler first so that they can prevent that paradoxic acute bronchospasm. Another thing that you need to remember, because of the fact it's an anticholinergic drug, the most common side effects of anticholinergics can be remembered via the rhyme: can't see, can't pee, can't spit, can't poop. Now, if you want to insert a rhyming word there to rhyme with spit, you go right ahead. But Miss Gilcrease won't say that to you. Because that means can't see being blurred vision a lot of times, can't pee being urinary retention, can't spit being dry mouth, and can't poop, of course, being constipation. There are no serious drug-drug interactions that are associated with ipratropium. We do want to assess for any medical complications to therapy, um, and it is a pregnancy category B drug. We do need to determine if the patient smokes, because of, again, some of the properties, with the drug that can actually, as far as that, the hoarseness, and as far as, the coughing and those kind of things, as well as making sure if they smoke that we're giving them proper education as far as that's concerned. These drugs are typically administered at home. However, we use them often in the acute care settings as well. A lot of times these will be included with an albuterol inhaler or an albuterol nebulizer in what we call a duo neb. If it's a duo neb, that means we're using albuterol and Atrovent together. Atrovent does a really good job a lot of times of breaking up some of the secretions and helping patients to mobilize those and get those out. Maximizing therapeutic effects, we want to explain the importance of taking it daily despite the absence of symptoms, because if it is a maintenance drug, keep in mind we want to make sure to explain to the patient it is not for rescue, it is for maintaining their disease process, so they need to take it every day regardless of if they're feeling better. Minimizing adverse effects, we do want to explain the importance of using it as prescribed to avoid systemic absorption. That can lead to an increased risk of adverse effects, because they're going to have more of those anticholinergic effects if they're using it more than prescribed. So we want to make sure to notify them of the importance of that. Patient and family education. We want to advise patients that it is used prophylactically, meaning before problems occur, and that the overuse could induce those unpleasant adverse effects. And we do want to assess their need for beta agonist drugs in addition to the ipratropium. If it's given in the nebulizer form, it's what we call a duo neb, meaning it's got two medicines, hence the duo. If it's given in an inhaler form, it's in the form of what we call Combivent, which used to be in an MDI, but now it's given as what's called a Respimat, which is just a different delivery device. So patients with a hypersensitivity to blank cannot use ipratropium, and that would be legumes, such as soybeans and peanuts. Those patients should not be given ipratropium. All right, and talking about xanthine derivatives, including theophylline, aminophylline, diphylline, and caffeine, come from a variety of naturally occurring sources. They are excellent bronchodilators, but they do not work as rapidly as beta-adrenergic agonist drugs. And so our prototype drug here is theophylline, or Theodure, you'll hear it called, or Theo 24. The biggest thing I can tell you about theophylline, we don't use it a whole terribly lot just in primary care. Pulmonologists do use it, and use it, pretty frequently. Well, I say frequently. They use it more often than primary care does. However, as we'll talk about in just a few minutes, and you'll see why, we don't use it near what we used to because of the fact of the beta-adrenergic agonist drugs that have come out. However, I can go ahead and tell you without question it will be on your NCLEX, because they always test theophylline on the NCLEX. Just about, I just about have never talked to a student that has not had it. So anyway, just to let you know, it's one that you're not going to see in practice too very much, but you will see it on your NCLEX. Your pharmacotherapeutics, it is indicated for the symptomatic relief or prevention of bronchial asthma and reversal of bronchospasm that is associated with CAL. It is used off-label for the treatment of apnea and bradycardia in premature babies, but that's, of course, an off-label use. It is administered orally or IV. It's metabolized in the liver, excreted in the kidneys. In the PO form, it peaks in 2 hours. In the IV form, it peaks in minutes. And it is rapidly absorbed in the GI tract. the pharmacodynamics, it is believed that the bronchodilation is caused by an inhibition of phosphodiesterase. It does also increase the force of contraction of the diaphragm muscles to draw more air into the lungs, which is another way that it's thought to improve that bronchodilation and to improve the bronchospasm that occurs in CAL. Contraindications and precautions: patients with hypersensitivity, patients with status asthmaticus or a peptic ulcer. We also should use it with caution in patients with cardiovascular problems, people such as those who have hypertension or arrhythmia because of its stimulatory effects. So with the adverse effects for theophylline, they are directly related to the serum levels of the drug. So as long as the serum level is therapeutic, as long as we're doing good from a therapeutic perspective, then usually there's not any adverse effects. But if the levels are too high, then that's when we get them. Most common adverse effects when those levels are off kilter: GI related, nausea, vomiting, diarrhea, and from a CNS perspective, headache, irritability, and insomnia. You will note that there are multiple drug interactions with theophylline, and that's another one of the main reasons why that drug is not given, why this drug is not given very much, because there's just so many potential interactions with it. All right, and looking at the health status, we do want to assess again for those contraindications and precautions for the to therapy for the patient. We also want to assess their pregnancy and lactation status and make sure that we're, aware of if the female is pregnant. We do want to assess if the patient smokes, because smoking cigarettes can decrease serum theophylline levels. And so if a patient smokes, we may actually have to increase their theophylline dosage. And so we want to make sure to assess for that. Of course, the IV formulation is given only in the acute care setting. Oral theophylline, of course, in any environment. In the hospital setting, we do want to administer theophylline at a rate of 20 milligrams per minute. And we want to make sure that we monitor those serum theophylline levels, with a normal theophylline level being 10 to 20 micrograms or mcgs per milliliter, which is the optimal therapeutic level. We want to make sure, under minimizing adverse effects, we want to monitor those theophylline levels carefully, and discuss any dosage adjustments that need to be done. That monitoring those levels carefully and frequently is one of the main reasons that it's not prescribed that much, because it does require quite a good bit of follow-up, and patients have to, you have to have a patient who's really willing to do that follow-up process. We do want to administer immediate release preparations with a meal to help decrease that GI distress. When we say now with the sustained release, it does need to be on an empty stomach, which is 1 hour before, 2 hours after a meal. But the big thing to understand is that monitoring those levels, because that can get quite cumbersome. Under patient and family education, we want to explain that theophylline will help make breathing easier, and explain the importance of taking it exactly as prescribed so that they can maintain those therapeutic levels like they need to. And again, we want to monitor them for potential adverse CNS and cardiovascular effects. With that, you also can put in there to make sure to monitor the levels, and that we're monitoring, making sure to teach them the difference between, the adverse effects, and when to notify the prescriber. So theophylline serum levels should be, and that would be less than 20 micrograms per milliliter, and that's to help prevent adverse reactions, because the adverse effects are related directly to the serum levels of the drug. At serum levels less than 20 micrograms per milliliter, adverse effects are uncommon. So you can see there, that's giving you an example of that narrow therapeutic index again, of kind of seeing that into action, because of the fact that it makes it very difficult to dose the patient correctly and get them to come back for follow-up and make sure that we're staying within that therapeutic range. All right, when we talk about anti-inflammatory agents, in addition to bronchodilators, we can use anti-inflammatory agents to manage respiratory disorders, especially asthma. We used inhaled glucocorticoid steroids. They are the most effective anti-inflammatory drugs available for managing respiratory disorders. We can give them orally, parenterally, or by inhalation. Again, parenterally, that's going to be any other application or any other route other than through the digestive tract. Your inhaled corticosteroid agents have become first-line treatment for persistent asthma. Now, with that, let me just say that when it says there that glucocorticoid steroids are the most effective anti-inflammatory drugs available for respiratory disorders, that is 100% correct, because steroids do a fabulous job of controlling respiratory symptoms. However, what has happened in the past is by patients taking steroids, like an oral dose of steroids, you get all the systemic effects. So what we ended up doing is that, scientists started studying it and doctors started studying it and said, hey, well, if we could just put the steroids just at the source of the problem, then, we could cut down on the systemic effects and we could still get the anti-inflammatory effect of the steroids. So that's exactly what they did with these inhalers. It's basically where you're inhaling the steroid and putting it at the source of the problem, which is in the lungs. The same way that an inhaled nasal steroid is used so effectively for allergic rhinitis, it's putting the steroids directly at the source of the problem, which is in the nasal passages and in the sinus cavity. So that's kind of where where this kind of came to pass, is from the standpoint that oral steroids work beautifully but just cause systemic effects. So our prototype drug here is budesonide, or Pulmicort. And our pharmacotherapeutics, it is used to prevent bronchospasm by decreasing the inflammatory response in the airway. And it is administered by inhalation. Its onset is slow. Its peak is rapid. Its duration is 8 to 12 hours. It is rapidly absorbed, but it does take 2 to 3 weeks for the effective levels, to get in the system. It is metabolized mostly in the liver and excreted in the urine. One thing I'll tell you about inhaled corticosteroids, I teach patients that these are your maintenance medications. These are not 911 drugs. These are not rescue. So these are the ones that I want you using every day, regardless of how you feel. These are not the ones to reach for if you are having a bronchospasm. That's when you need that 911 inhaler. Pharmacodynamics, they do inhibit the production of leukotrienes and prostaglandins through interference with the arachidonic acid metabolism. The decreased swelling associated with inflammation and promotion of the beta-adrenergic receptor activity, which may promote smooth muscle relaxation and inhibit bronchoconstriction. It does reduce migration and activity of the inflammatory cells and increases the number of the beta receptors, and enhances responsiveness of the beta receptors and decreases mucus production as well. Contraindications and precautions. Anyone with an active systemic fungal infection, they do not need to use the inhaled corticosteroids. During an acute asthma attack or status asthmaticus, again, do not need to use it then as well. because of the fact that it can actually cause some increased problems. And if it's given in combination with one of those LABAs, like we were talking about earlier, those long-acting beta agonists, and someone uses it during the middle of an acute asthma attack, it can actually induce status asthmaticus, as well as it's not going to help during an acute asthma attack, so that's why we don't want them to reach for it. Adverse effects: sore throat, hoarseness, coughing, dry mouth, and pharyngeal and laryngeal fungal infections. If you've ever heard of someone having thrush or a fungal infection in their mouth or a yeast infection in their mouth, that's that white, thick coating on the tongue. That's what patients will get from these inhaled corticosteroids if they're not careful. The biggest complaint that I get from patients out of it is the sore throat and the hoarseness. In children, there has been some research that has been done. I don't think anything that's been definitively proven yet, but that in children, long-term use could delay their growth patterns. So, we try to use them with caution as much as possible, but there's definitely some evidence that they were exploring in that regards. There are no important drug-drug interactions with budesonide. We do want to assess for signs of an active lung infection, making sure that they don't have an active infection going on that we could, be exacerbating. It is a pregnancy category C drug. We do want to use caution with them smoking, and caution them about smoking. Again, from, just the smoking perspective, because of the fact that it will decrease the efficacy of the drug. It is used primarily in the home setting, but can be used, in other settings as well. We do want to instruct them to take it every day, regardless of how well they feel. It is a maintenance drug, so they need to take it, for that reason, to maintain their improvement in their disease process. If they're going to be using a beta-2 agonist, which, like we talked about before, is like your albuterols, your Zopanexes. If they're going to be using one of those, they need to take it first, and then use the inhaled corticosteroid. Again, the reason for that is in that same line of thinking with the acetylcysteine, because of the fact that you want that beta agonist to work, to open up, to dilate everything, so that you can actually get the budesonide down into that bronchial tree further, so that it's able to hit that inflammation harder. In order to minimize adverse effects, you can use spacers to help alleviate the dysphonia by filtering some of those larger aerosol particles. Dysphonia being that hoarseness and that patients will complain about that they get. Patient family education is important for inhaled steroid therapy, to explain things to them. Also, the importance of daily use regardless of the absence of symptoms. Biggest one that you want to teach them about is to rinse their mouth after administering the drug. Just to take and rinse some water around in their mouth and spit it out, because of the fact that they definitely need to do that, so that they don't end up with getting thrush or getting that fungal infection in the mouth. Ongoing assessment and evaluation: you want to assess for a decreased incidence of acute asthma attacks. And I will add to that an increase in their ability to complete their ADLs, because that's where I tend to find most often that, that patients can see that this medicine is working, whereas they used to could only walk maybe, to the mailbox, halfway to the mailbox without having to stop to rest. Now they can walk to the mailbox and back without having to stop to rest. And if they're having to use that rescue inhaler more, if they're having to wake up in the middle of the night and use that rescue inhaler, those are signs that we need to change up on the maintenance therapy and maybe, adjust dosage on it versus, actually increasing their rescue doses or whatever. Because if we're getting their maintenance therapy correct, then they will not rely on that rescue medicine as much. So those are drugs that are closely related to budesonide. A lot of times they're going to end in the azone suffix, which would indicate to you that it's an inhaled corticosteroid. So patients using budesonide are at a high risk for developing, and that would be an oral fungal infection. Oropharyngeal Candida albicans infection is a common adverse effect associated with daily use of ICS. Also, again, commonly known as thrush. You can see that white coating there at the back of the throat, and you can't see it really good on the tongue there, but back here in the back, which is an adverse effect of using the inhaled corticosteroids and not washing their mouth out. So the way we help them prevent it is to teach them to wash or rinse out their mouth after they use it. All right, so next we've got the leukotriene receptor antagonist. The leukotrienes are inflammatory mediators that are powerful bronchoconstrictors and vasodilators. They've been identified as important mediators in the pathology and symptomatology of asthma. They do result in airway hyperreactivity, bronchoconstriction, and hypersecretion. Our prototype drug here is zafirlukast or Accolate. The one you're probably most familiar with is Montelukast or Singulair is the brand name of it. All right, so our pharmacotherapeutics is for the prophylaxis or treatment of chronic asthma. Our pharmacokinetics, it is administered orally, metabolized in the liver, excreted in the urine and feces. Pharmacodynamics, it blocks the receptors for the leukotrienes bound to the amino acid cysteine. The cystenyl leukotrienes are potent bronchoconstrictors, approximately 100 to 1,000 times more potent than histamine. So if we block them, we substantially improve the wheezing, the coughing, and the dyspnea that is associated with asthma. So this specific leukotriene that's bound to the amino acid cysteine, those leukotrienes are such potent bronchoconstrictors. They're approximately 100 to 1,000 times more potent than histamine is. So if we block them, we're going to substantially improve things. In looking there at the pharmacokinetics, your peak action is noted as early as day 1 on zafirlukast. However, it's more commonly it takes up to about 2 weeks to see improvements. All right, contraindications and precautions. Hypersensitivity to the drug. Also, if they have a hypersensitivity to povidone, lactose, titanium dioxide, or cellulose derivatives, because those are all inactive ingredients in the tablet. It is contraindicated in breastfeeding. It is contraindicated for acute asthma symptoms. It is used for maintenance, not for acute situations. So we need to be careful in those as well. Adverse effects, headache, dizziness, gastritis, nausea, vomiting, diarrhea, abdominal pain, pharyngitis, rhinitis, arthralgia, which is joint pain, myalgia, which is muscle pain, fever, back pain. Also, when we're talking about contraindications and precautions, we do need to use caution in patients who have hepatic disease, those who are 65 years old and older, because of a decrease in the drug clearance. So we need to be careful in those patients. And I think under adverse effects, I told y'all fever and back pain, but just in case I didn't, fever and back pain also listed as adverse effects. Drug interactions, theophylline, warfarin, aspirin, erythromycin, and drugs metabolized through the P450 system. So there is going to be where, like I was talking about, that, I'd let you know if it was a P450 drug and all. That would be this particular drug. So it needs to be monitored appropriately and used cautiously with other drugs that are metabolized that way. All right. For the health status, we do want to assess their medical status and their liver function to make sure that they can correctly metabolize the drug. It is a pregnancy category B drug. It is not recommended in children younger than 5. We need to be cautious with that. That if patients are taking it that are younger than 5, we need to double check that with the provider. It does need to be taken on an empty stomach. The reason why is because food decreases the bioavailability of the drug by about 40%. So that means that with taking it with food, it makes it to where there's very little of the drug that is available, or almost half. It's decreased almost half of the available drug out there to actually work. So definitely needs to be on an empty stomach, and it's generally given at home. Maximizing therapeutic effects, we want to ensure that the patient takes Zafirlukast twice daily despite the absence of symptoms. That would be the reason why Singulair or Montelukast has become more common, is because of the fact that it's only taken once a day. Minimizing adverse effects, we want to ensure that the patient takes the medication exactly as prescribed. We do want to assess if they're taking steroids, systemic steroids, or if they're tapering them, because you can have a serious adverse effect of Churg-Strauss syndrome in patients that are taking Zafirlukast and that are having systemic steroids withdrawn. So we just need to assess if they're taking systemic steroids so that we can monitor them a little closer. Patient and family education, we want to explain that it is maintenance therapy and encourage them to take non-narcotic analgesics if a headache occurs, such as Tylenol or acetaminophen that they can take for that. We want to assess whether the patient needs any beta agonist drugs in addition to the Zafirlukast in order to, help with their asthma symptoms. And Zafirlukast is used for prophylaxis or for treating chronic asthma. And there again is the little kitty cat with his spacer and using it appropriately to get his treatment. So